A very warm welcome to today's webinar entitled Cancers of Unknown Primary, Challenges and Opportunities. The NCRI programme of virtual events delivers an ongoing programme of education and innovation for the global cancer research community. This week's event is aligned to the NCRI Living with the Beyond Cancer initiative. For further information on this and our future webinars, please follow the links in the Q&A box. We are delighted to welcome today Chair Dr. Shiu from UCL Cancer Institute, who will introduce today's eminent speakers. Dr. Shiu, over to you.
So good afternoon, everyone. I hope you can see me. I'm Kai-Keen, and I'm going to first of all just get my slides onto screen. Sorry about this. Okay, so hope you can see this. So welcome to this webinar. I have to thank the NCRI team for inviting our work stream from the Living with and Beyond Cancer CSG to give a 1 hour discussion and presentation on some of the advances but challenges and opportunities we have now to treat patients living with cancer of unknown primary. Please use the NCRI virtual hashtag as well as #CUP if you do want to use Twitter. So my name is Kai-Keen Shiu. I'm a GI and CUP oncologist at University College London Hospital NHS Trust. And my role for today is to be chair of the meeting, but also to give a kind of overview of some of the background to our management of cancer in primary, and I'm the chair of the work stream, and I'm delighted that then I will have my colleagues, Dr. Clive from Edinburgh and Natalie from the Christie to then give the main talks. And at the end, we'll have a panel discussion with John Symons, who's the founder of the CUP-JO Foundation, Gillian Knowles, who's a nurse consultant CNS in Edinburgh, and ourselves. And what we'll do is there's a chat function which I'm happy for you to ask questions, and as we go through the talks we won't really pause until we finish all 3 talks, but please do ask questions, and also the audience, please like the questions you like, because I will look at them and the highest voting likes I'm trying to push into the panel discussion. Okay, so I'm going to go straight to the start of my talk. So I've got the job of kind of introducing kind of the overview of management of cancer in primary, and also just to understand what our role is as part of the NCRI MEO CUP workstream, which is a new role where the CUP team kind of sat within the upper GI CSG, but we now have a more prominent role within this new CSG. So this is the challenge we have for our patients, and we all face really, whether we are medics in a healthcare profession or friends or family of patients who are being initially diagnosed with cancer. And the good news, I guess, is that the incidence of this definition of cancer in primary is certainly falling in the UK, and the mortality is going down. As you can see, in 1996 we thought there was about 15,000 deaths. Now it's maybe less than 10,000. It's still pretty common, and of course it doesn't feel common maybe in a lot of places because it's rare and it sits in ends of various MDTs. But I think that with the new guidelines from NICE, which is defining what we really mean by cancer of unknown primary, we're going to do better. So just as a definition, MUO, malignancy of unknown origin, is really when we have got 2D imaging and we haven't really usually got a tissue diagnosis. Provisional cancer in primary is when we've got a tissue diagnosis of probably an epithelial-like cancer, and most of our patients hopefully from that point can be turned into a primary cancer, but occasionally we don't get it, and very rarely then we've got the true CUPs. And I think this is an important thing to understand, that in the past you may have heard friends or relatives saying, you know, my mother, my father, my friend, you know, they didn't know, you know, what was going on, and you find out actually they were clearly not very well before they were admitted to hospital, and they didn't get to the point of even having a tissue diagnosis. So this is partly why we've got to be very careful about when we see some of the headline figures, and this is just some data from NCNI where they say the 1-year survival rates for CUP is poor, 16%, but that is actually lumping previously all patients who didn't even have a definite tissue diagnosis and who were really not fit for any treatment. So of course, the idea now with the of MDTs and CUP MDTs is that we embrace that uncertainty and we take on those challenging cases and we try to get those patients to determine whether they're fit for treatment and what treatment we can offer them. And even if they have a true CUP, we can offer them more than just standard chemotherapy or radiotherapy. But it's really important to understand that if we identify the patients better, define what we're actually doing, and actually saying what are we treating, then I think actually survival percentages are better. And I'll show you a bit of real life data later from UCLH. And we have got guidelines. We've got ESMO guidelines for the clinical management of CUP. We've embraced them in the UK as well. And the most important thing is to make sure that we're not missing very obvious things like melanoma or lymphoma or testicular cancer. And also be aware there's what we call good prognosis CUPs, which are patients who may have just axillary lymph nodes, peritoneal disease or single site disease, and then the really bad CUPs, which I'm sure many of you have seen in hospital and A&E, and they do look really bad with carcinomatosis. But even then, there are still patients who we can offer them treatment. Now, one of the controversies, which we'll probably address in the later things, is about that there's no definite process of saying that doing genetic profiling or gene expression profiling is mandatory. Now, I think we should be changing that idea. NCN in America say that we should be doing it, and judicious use of what called molecular classifiers. And one of the main CUP gurus, Tony Greco, has said basically, unless you do that, there's no way you can really work out how to treat these CUP patients. Okay. Now, I think we'll go through it in the talks, but my general feeling is that we're already doing these profiling for our common cancers like lung cancer, breast cancer, ovarian cancer, bowel cancers. So common things are common, CUP presentations are rare. It's more likely to be a common cancer with an unusual presentation like CUP. So we should be doing profiling, but let's discuss that later. I think the holy grail, okay, of CUP is the tissue of origin test. So we've gone through the standard tests. We still don't know what's going on. Can we use the biopsy from the metastasis to find the primary? And we've been trying very hard, and we use various profiling techniques. And this was one a few years ago by Rosetta Genomics, who used actually the idea that, if you've got undifferentiated cancer, you've got an inhibitory RNA suppressing the expression of the normal protein. So why don't you use a mRNA profile? And it was felt to be good. They validated it. They published it. They charged us a lot of money, and we did try a bit. It was a bit disappointing, usually a one-sentence answer, and sometimes it just didn't feel right to us anyway. So it's almost like, what are we doing? And unfortunately, it's shown not to improve outcomes, and actually, unfortunately, it's not been commercially viable, and it's filed for bankruptcy. Since then, and I'm sure hopefully Natalie will mention a little about this, we're trying other ways of trying to find the primary using epigenetic profiling, methylation profiling, and this is promising. And this is a lovely paper in Lancet Oncology by Manuel Estella, and that is being commercialized, and we might talk about whether that's the way to go. But really, at the moment, we don't have a really gold standard tissue of origin test. So, based on that, you can see that although I do acute oncology and a lot of the panel members are part of that, we really feel that for these patients who have got, provisional or confirmed cancer in primary, we've got to do better for them, and we've got to a degree separate part of the kind of frontline things of what's going on in the ED setting. Clearly, some of those patients funnel through to us, but many don't. And really, if we're going to improve things for our patients who are living and going through the process of being told they have a cancer in primary, we've got to separate that from acute oncology. Okay, and as we are now part of this Living With and Beyond Cancer group, which has got a number of work streams, as you can see, so we're one of the others, acute care and toxicities, which very much deals with also acute oncology, late consequences of treatment, advanced disease, and a methodology work stream. And it's reflected in our work group. We've got a really great panel of real great members. So I'm the chair, Sally's my deputy, Claire Mitchell at the Christie, and Sonali at the Villandre in Cardiff. So we've got good UK coverage. We have to have a pathologist, Manuel at UCL, Ben Taylor at the Christie, Gillian, who works with Sally up in Edinburgh. We have a research methodology in Southampton, Richard Wagland. And very importantly, we have patient representative, Jan Rose and John Symons. and a trainee representative, Alyssa, who's actually doing a PhD on CUP with Natalie. So that's our group. And with that group, we've been working on that. What are we trying to do here? So as I said, you can see that in terms of our strategies and what we want to do, they're moving really rather away from the acute MUO, though, as I'm sure Sally will show us, there are some really important things we are trying to do in the frontline setting when patients first present to A&E. And the first thing is to make sure that the investigations we do are timely and appropriate, okay, in that initial management. And yes, try and find tissue of origin tests and novel diagnostics to work out what patients we really push the diagnostics and treatments and which ones we shouldn't. And really importantly, we have a spectrum of the patient kind of patient view of this. So quality of life, patient reported outcomes, patient reported experience, and I'll talk a little bit about some patient decision aids. Of course, what we really want to do is if we really can't find where the primary is, we want to, whatever we try and then offer them, it's actionable and it's treatable beyond standard platinum-based chemotherapy. And again, we'll talk about whether we should not only have CUP MDTs, should we have CUP tertiary SMDTs, and even now genomic boards. We're going to talk about novel biomarkers in the next few speakers. We want to design trials if they're not already existing. And we want to also look after the poor performance CUPs who may not be able to access a trial. Again, really important to get good quality of life, PROMs and PREMs, as I'm sure Natalie will talk about later. And I suppose if there's not available study, then we've got to create one, and we've got to get our patients to access clinical trials, because that's really what patients want. If we want any patient now with diagnosis of cancer to try and be on a clinical trial, and that's the best way to test any treatment or management strategy. And the other thing that we'll talk about is really at the end of the day, we're going to ask good research questions. We need a biobank, and Natalie will cover some of that in her talk about biobanking all these samples so we can we'll look back and create our own studies and also collaborate internationally. And I have to thank John here, head of the CUP Foundation, of this really good slide, the patient's perspective of what they say and what we think. And this is a double blow, the double agony that in this day and age with whole genome sequencing, why can't we find the primary? Why doesn't the oncologist even know after they've gone through a very long pathway of investigations? And of course, the standard things that any patient with advances would ask: how long will I live? How deal with uncertainty? You know, how quickly should I start treatment? What do I tell my friends and family? If it's young, is it hereditary? And most importantly, is there a trial? Is there research I can participate in? And I have to thank my colleague John Bridgewater at UCH, and I would say the challenges and opportunities for novel CUP therapies are, again, things that all our cancer patients living with cancer are asking about. A lot of cancers now, we want to profile the tumor. Can we find something that is alteration? Is there a treatment we can match to it? Can we access the treatment? And the red one is, well, actually, will I respond to the treatment? And we really, that is a stressful thing for any patient living with cancer, and possibly more so patients with the double uncertainty of living with cancer and primary. So we've got to understand those patient expectations. So one of the things I want to just show that we're trying to do at the front end through the NCI group is that on John's website, the Cancer and Primary Foundation, which I really encourage you to look at. It's an amazing website which very few other countries, patients in other countries have. We have 5 cancer and primary patient decision aids. So they're here in the treatment, and I've just highlighted it here. And there's 5 of them, and I'm just going to show you one of them. And this is the point where patients are being offered potentially extra genetic profiling, and do they want to proceed with this? And I really like these because they've been designed with patients in mind and with John. And actually, I would use them, to be honest, for some of my other patients living with other cancers. But you know, one of the most important for me is to have treatment that controls my cancer and gives me the best chance of longer life. Okay. All the way to, I don't want to spend too much time and money on a new test where there's limited evidence. And indeed, I don't want a new drug treatment for cancer, even of a fine genetic profile. I just need to focus on symptoms and my own kind of patient outcomes. And how do you rate that? So those are things we can offer our patients, but we also are trying to see as a group whether, in fact, is important and how useful these tools are. So working with Richard and the team, we've also got known decision-making scales, and we're going to actually work out how useful they are. So we're piloting that across our various centres, and we hopefully will show you some of that data in the future. Just to show you some real life data, this is from a while back, but with some follow-up. So this is my CUP immunity, which when I started at UCH was about 2013. And what you can see is that these are what I call the true CUPs. We probably get about 100 referrals into MDT a year. Not many, because I run AOS, I try to divert a lot of MUOs to the relevant MDT. So these are what I call pretty difficult CUP patients. And also then at that point, we are saying this is a 4 or 5 year period. Probably I'm only treating maybe 12 to 15 true CUPs. And we do try a number of treatments for them, okay? And what you can see is that in terms of overall survival, still under a year median, but 1 year survival is now high at 40%. Now, a lot of our patients we felt were fit cancer in primary, so median PFS, PS of 1.5. And in that point, you kind of think, well, if you only have first-line platinum, the next step is usually a clinical trial. And we want to get people into clinical trials with good performance status. And in that way, I'm sure Natalie and Sally will talk about their experience of trying to put cancer in primary patients into kind of basket studies. But in those first few years, we really only had a couple of patients onto what I call true IMP studies, but now we've got many more in the last couple of years. Why is that? Well, I'm just going to show you an example, which is a really good study called the Capisco trial, which is a global trial phase 2, and it's got a lovely design of essentially giving people induction platform platinum. And before we start that treatment, we do molecular profiling both in solid tumor and blood. And then if you respond, you can get randomized in a very generous 3-to-1 fashion to targeted therapy. Okay, and if you don't have a targeted treatment like EGFR or BRAF, in fact, you combine immunotherapy with chemotherapy. Okay, and it's very, very good because actually, even if you progress on induction chemotherapy, you still be able to enter the arm of some molecular therapy, which is great. So the only small group of patients who don't get molecular therapy in their first-line setting is the one that has to continue their treatment that they're responding to. But even then, after they progress, we have access to all their profiling and we can use that for phase 1/2 trials. So I won't run too much on it, but this is a really nicely designed trial, which I also say is a beautiful design trial for many now trials that we would do in other cancers, such as lung cancer, bowel cancer, cholangiocarcinomas. And it's been very mobile because you can access other arms and change extra arms as required. So going back to what does the CUP patient really want, I think this is what most patients want with advanced cancer, is to live much longer with good quality of life, make a diagnosis, but partly now just to say, can we make a diagnosis I can offer targeted therapy, and of course be part of research trials and offer feedback. In terms of us as people in the front line, as also CUP oncologists and nurses and people who work with us, we want rapid referrals, we want appropriate investigations, and we definitely want to have that holistic support, really important, early in the pathway, again, which we really should offer to all our cancer patients. So in summary, for my talk at least, I think the CUP biology is still not well understood, but I'm hoping with the next few speakers you'll understand that better. It's really important to have good cross-silo, multidisciplinary working, and now international collaboration for a rare tumor type. We cannot underestimate the importance of patient involvement and feedback in this, in anyone, but in particular in this group, and we've got some really good work coming through for that. And just be aware that absolutely, whether we're doing it in the UK, but we're going to show what we're doing in the UK, but also internationally, feasibility studies and efficacy of novel treatments are always being developed now, and it's a really hot topic, I think. And again, please, happy to share. These slides will be shareable, and please use the Twitter feeds to share this. So I'm going to just now introduce my colleague, Dr. Sally Clive, who's a good friend of mine, who's a consultant medical oncologist who actually does GI and GI colorectal and CUP, as well as early phase studies in Edinburgh. And she's going to talk about some of the work she's been doing around prognostic and predictive biomarkers for MUO and CUP. Thank you, Sally.
Okay. Can you see my slides? Are you able to see my slides?
Yes, Sally, I can see your slides. If you can make them into slide view.
Okay. Is that all right? Yeah?
Yeah, perfect.
Oh, great. Thank you. Sorry about that. So yeah, my name is Sally Clive. I'm a consultant medical oncologist in the Edinburgh Cancer Centre, and I've been working in the CUP team now for 10 years, really since the time of the NICE guidelines about MUO and CUP. And we've been taking referrals both with MUO and CUP, so we do our MDT, and we've been keeping a comprehensive database and biobank of all those patients, and we've now got about 1,250 patients in the biobank database. And it's really using that information that I'm going to present some data today. So Kai-Keen has shown this slide, and I'm just going to briefly touch on it, but it's just as a reminder of these definitions, because as Kai-Keen said, there is still a significant lack of understanding, I suppose, of the different definitions and crosstalk amongst what people call CUP. And a lot of people call, when they say CUP, they actually are referring to patients presenting at the front door with disseminated malignancy who may or may not be fit for further investigations. And those would now be classed as MUO, or malignancy of undefined origin. And when those patients are referred to us, we do discuss them through the MDT, and we give advice or see patients on the ward as per a lot of acute oncology teams. But we also will bring patients with CUP to our clinic. So we have a diverse practice where we see both groups of patients. And I like to think of patients falling into three main groups: those with good prognosis who are highly treatable, and those are the subgroups, the favourable clinical pathological subgroups that Kai-Keen referred to earlier that are in the ESMO guidelines. And most of them don't come through CUP teams, actually. Most of them are seen through tumour-specific teams, but a few of them will come to CUP, such as poorly differentiated node-dominant cancers or neuroendocrine cancers. There's then the MUO group, which would be our end of life or unfit patients who are really not fit for a biopsy or further investigations, often with very poor performance status or premorbid frailty, often presenting to the front door with highly symptomatic cancers. And what we felt was important was to see if we could work out some prognostic markers in all of these groups, because whilst the potentially treatable group is the group that come to our CUP clinics and that we see to discuss treatment, and we hope that many of them will be suitable for either SACT, clinical trials, radiotherapy, or a mixture of all of those things. Unfortunately, a lot aren't, and we wanted to understand better how to guide our colleagues in the acute oncology teams and acute medical teams as to who should not be investigated further, and also which patients are most likely to do best with treatment. And so to do this, we analysed the first 1,000 patients referred to our team that we have comprehensive information on our database from. And we worked out which groups they ultimately fell into and what their outcomes were. And as you can see from this slide here, that we had 1,000 patients at the outset through the MDT. Of them, nearly a quarter didn't go to biopsy, were not fit for further investigation, and they were not seen in an oncology clinic. Nearly more than 3/4 did have a biopsy and went on to be seen and discussed again and seen in our clinic if appropriate. And interestingly, of those, nearly 400 actually a primary cancer was identified, and they were sent on to a site-specific team. A small subgroup, 74, about 8%, actually ended up with a cancer a diagnosis that wasn't cancer, and they're an important subgroup to remember about when we discuss these patients with MUO. And about a quarter ended up with confirmed CUP and came to our CUP clinic. Our treatment rates seems to be lower than Kai-Keen's, in that we actually only treated 70 of those with SACT, but we probably see patients pretty quickly from our acute oncology type service. So a lot of those were already deteriorating or not able to be treated with SACT, and had they had to be referred on to another centre, they might not have ever made it. So actually only a quarter of patients seen in our clinic were treated with SACT. And we wanted to understand the outcomes. So here are the survival curves looking at these different subgroups, and we can see that obviously the non-cancer diagnoses have done pretty well, as we'd hope, but those in whom a primary cancer was identified when they present through this metastatic pathway actually don't do particularly well, with only just over 1/3 alive at 12 months. When it comes to the confirmed CUP group, a quarter alive at 12 months and 2/3 alive at 3 months. But with our MUO, or provisional CUP, that is, they had a biopsy but never made it to further investigations or a CUP clinic, their outcomes are really very poor, with median survival of just over a month and almost none making it to 12 months. So what do we know about prognostic and predictive factors? Well, we know that the favourable clinical pathological subgroups should be treated as per their tumour site, and that's been well shown over the years. We know that good performance status patients always do better, and obviously with no comorbidity and normal organ function, they'll get a better chance of good systemic therapies and do better. Petrakis looked at different prognostic factors in a study of 311 patients referred to a CUP clinic back in 2013, and showed a number of factors on univariate analysis, including LDH, ALK-Phos, and so on. But on multivariate analysis, only 3 factors came out as being associated with worst survival: performance status, elevated white count, and visceral metastases rather than nodal metastases. They produced an iScoop score, which is somewhat complex and I don't think widely used, to try and bring those things together. And that got us thinking about the white blood count, about work done by Donald McMillan and Barry Laird on the Glasgow Prognostic Score, which is a score using albumin and CRP to look at the systemic inflammatory response and how this predicts for outcome. And that's been studied in over 60,000 patients within cancer clinical trials and has been shown to be an independent, validated prognostic marker, such that if the CRP is above 10 only, associated with an albumin of less than 35, that gives a score of 2, and that predicts for poor outcomes. A GPS of 0 with a CRP less than 10 and an albumin and any albumin do much better. And we thought we'd like to look at that in our group of patients. So we looked at it in our 1,000 patient database, and you can see here that GPS 0 is the upper graph, GPS 2 is the lower graph, and that it does indeed predict for outcome, with people with GPS 2 having really a very low median survival. And this we thought was very helpful in that when we're making decisions about whether or not to investigate further or biopsy with the patients with MUO, that this provides some objective evidence based on bedside blood tests, very easy to remember, that gives us additional ammunition, I suppose, not ammunition, but discussion points to discuss with the teams and the patients as to why further investigations might not be appropriate given the expected very poor outcomes in these patients who often present with very advanced metastatic disease, which is essentially untreatable. We also wanted to look in our confirmed CUP subgroup, which, if we'll remember, was a lower number, that was 254, and we looked at GPS in our confirmed CUP group, and again we found it to be prognostic for outcome, with people with GPS of 0 doing significantly better than those with GPS of 1 or 2, in whom the survival really was very poor, particularly those with GPS of 2 with a high CRP and low albumin. Within this subgroup, we treated 70 of those with SACT, and we were interested to look to see if it was predictive for response to SACT. And again, we found that the GPS were predicted for response, that those with GPS 2 had the lower survival, even despite systemic anti-cancer therapy, and those with GPS of 0 had a greater chance of survival, both median survival and overall survival. So we found that the GPS could be prognostic both in the MUO group and in the confirmed CUP group, and predictive for response to SACT. And we find this very helpful, and we use it routinely in our practice in helping us guide some of these very difficult discussions with patients when we're deciding about further investigations in the acute oncology MUO setting, or whether we're deciding about systemic treatment in those with confirmed CUP. If we remember Petrakis' work, they also talked about radiology. So we took 300 of our confirmed CUP patients in our large database, and we looked at prognostic radiological features. And again, we've got lots of graphs, but I won't show them today. But we did show in the 300 patients that we looked at that there were better outcomes in those with a single metastatic site or node-only disease, and worse outcomes in those with visceral metastases or metastases in more than one body organ. And that again is in keeping with the work done by Petrakis. So in summary, looking at the prognostic factors in MUO and CUP, that performance status is always extremely important. We know about clinical pathological subtypes as previously described, and the favourable groups do better. Radiological features suggest that node-only metastases do better, or if metastases are in a single site or limited to one body organ. And we've also shown that the Glasgow prognostic score is highly predictive for outcome, with a GPS of 0 being having the best outcomes. Importantly, and this is both for the MUO and CUP groups, we showed that a GPS of 2 is associated with a really very short survival in patients with MUO, but is also associated with poorer outcomes in patients with CUP. Within our small subgroup of patients, this seems to be maintained in patients in both the favourable and unfavourable clinical pathological CUP subgroups. And a GPS 2 seems to be associated with worse responses to systemic therapies. However, we do acknowledge that this is based on pretty small numbers by the time we get down to those treated with SACT, and we're very interested in collaborating with the rest of the NCRI CUP subgroups to look further at this with greater numbers. I think it is important to bear in mind that this is not a standalone predictor for outcome or response, that these things always need to be taken in the clinical context. For example, a very good performance status patient, we would take note of the GPS, but we would still manage them as per usual. And we have had patients who have GPS 2 who've done very well. Or if they've got a concurrent infection that may be causing the rise in CRP or the low albumin, that obviously that requires treated first, and so it could be discounted under those circumstances. Although when we did our analysis, we took all comers, which will have included some patients who had infection when we checked their CRP. So we find this an interesting area to look at, and also very helpful in our clinical practice, both for MUO in determining who should be investigated, and also in CUP in helping guide treatment decisions. We're looking forward to further collaboration through the NCRI CUP network to get greater numbers in the smaller subgroups, to validate GPS as prognostic in confirmed CUP, and also to investigate a new prognostic score that we're looking at, simplifying things even further to just look at white cells and albumin, both in MU and in CUP. We're going to be interested in looking at both of these scores in both the good and the poor clinical pathological CUP subgroups, and to see whether they're predictive for SACT response. And ultimately, we'd be really interested in integrating that with further information, the detailed information on histology, molecular subgroups, and people with genetic aberrations, to see whether we can build a more comprehensive prognostic score for treatable CUP patients. And so in my final slide, I'd just like to acknowledge all those who have helped maintain the database and do the analysis, in particular Mark Stairs, who's done a lot of work on the database and on the prognostic group analysis, and the rest of my colleagues and patients in the CUP team in Edinburgh. Thank you very much.
Thank you so much, Sally. That's a great talk. I just want to say that please put in any questions you like. I certainly have got some questions about what you've said, Sally, but please don't be afraid. Ask some questions, and I will ask any audience questions to the panel later. So we move now on to my other good friend and colleague, Natalie Cook at the Christie, who is a phase 1 medical oncologist, but has a particular interest in cancer in primary, and runs a clinical research program, and even with a student. So Natalie, over to you. Looking forward to your talk.
Thank you. Hopefully you can see my slides. So I'm going to talk today about clinical trials and research opportunities in CUP. Hopefully the slides are moving on. So with the diagnostic challenges that we've discussed today, this also brings research opportunities in CUP. We've talked a little bit about tissue of origin, and can we determine the tissue of origin by molecular profiling? And I guess there is already publication to show that we can do that, but we haven't yet shown that it improves outcomes. Is there a unique common biology behind CUP tumours? And this has not been described to date. And can we detect the molecular driver mutations to direct therapy in CUP, as we can do in other cancers now? And I guess we can actually detect these molecular driver mutations. However, access to the majority of targeted therapies and immunotherapies is still mostly tissue type specific. But both of these are important for treatment decision making and access to these therapies. We also know there's an issue with CUP patients with access to tissue samples, And is there an alternative to this? And we now know that the world of liquid biopsy is emerging as a significant advance, and hopefully we can use these in our cup patients. Again, the ESMO cup guidelines have already been shown today by Kai Keane. And really the two things I want to get out from this is that, as is mentioned by Sally, there's a specific subset of cup patients that do better. These are the patients that we can identify as being kind of very specific cups, and we can refer them to site-specific teams for further management. And they're treated in more of a site-specific way, a disease type specific. However, the vast majority of our cup patients are non-specific subsets, so the poor prognostic subset. And unfortunately, these patients have worse outcomes and have worse survival. Ultimately, what we want to do with our research is to try and make sure that we can have specific subsets for all those patients with a cup diagnosis. Even if we can't find the primary, we need to be able to improve the outcomes and prognosis. And we think by trying to develop specific subsets of cups, we can do that. So in Manchester, we've developed over the last few years a kind of cup research and clinical team to try and develop cup research. My primary role is within early phase clinical trials, so I treat all different disease types, including rare tumours, so that lends itself quite nicely to treat cups as well. We've set up a nice cup biobank so we collect tissue and blood from all of our patients that come through our clinic, and we also have an ethics approved project to collect archival tissue. We work very closely with the Manchester Centre for Cancer Biomarker Science under Professor Caroline Dive. So now we have access to longitudinal cfDNA or liquid biopsy analysis for patients on treatment. We can do a number of different techniques such as mutation and methylation patterns. And we're trying to develop advanced cultures and other techniques to understand more about cup biology and heterogeneity. And importantly, we also need to understand immune markers that could be relevant for cup patients. I just want to mention the PhD project that Dr. Alicia Conway is doing, who sits on the CUP group. So Alicia is looking specifically at the role of liquid biomarkers and some tissue biomarkers that we hope can be used to improve diagnostics and management stratification of patients with CUP tumours. We're looking at this to try and predict tissue of origin, to identify predictive biomarkers for CUP, and ultimately identify these more favourable subtypes that we think exist, and to try and hopefully eventually get rid of the unfavourable subset of cups. So going on to national cup clinical trials. So there's two large clinical trials that are ongoing at the moment in the UK. The first one is called CUP-M, which is led by Harpreet Wasan out of Imperial. This is a phase 2 two-stage trial of pembrolizumab, an immunotherapy drug in CUP. There are two cohorts of patients. The first cohort is where patients have received chemotherapy already, and the second cohort is where CUP patients have not received chemotherapy. And as far as I'm aware, both cohorts are still recruiting patients at the moment. The largest global study to date is called the Capisco trial, and this is a commercial trial sponsored by Roche. This is an international phase 2 trial taking place in 35 countries and over 155 sites, which is a huge, huge ambition. And I really think this is going to be a game changer in CUP research. The UK is one of the leading global recruiters to this trial, just behind Germany. And I think that shows how much we value CUP research within the UK. And in the interest of time, I can't give too much information about these, but for anyone that may be interested on these trials, if you go to the CRUK website, the link's just below when we share the slides. If you go on to find a clinical trial and put in CUP, it will tell you more information about the eligibility criteria for these trials and the sites that are running throughout the UK. Kai Keane's already shown a very similar slide to this about Capisco, and Capisco, it's a huge trial. It's quite a complicated trial, as you can see from this slide, and it's taking a very specific set of CUP patients to go on this trial. Patients have to be very fit and well to go on this trial. They have to have measurable and biopsiable disease. And obviously, you know, it's not for everyone to go on this trial, but I think for the patients that do go on this trial, they have access to this number of molecularly targeted drugs, they have access to immunotherapies potentially, and hopefully over the next few years, we'll see the results of this coming out and may even change the pathways for CUP patients. Back of this, we've designed an investigator-led trial within the UK called CUP-COMP. This is due to open hopefully later in May. This is to assess and compare the genomic sequencing in tissue and in blood for the diagnosis and treatment stratification of patients with CUP. Again, this is a big ambition of us, and we work very closely with the pharmaceutical industry for this. Roche have been a big supporter of CUP research. We managed to secure funding from this from Innovate UK, and it'll be a national trial with a good geographical spread across the UK. We'll hope to provide real-time tissue and blood molecular profiling through whole genome sequencing in the tissue and targeted sequencing panel in the blood using the Foundation Medicine panel from Roche. We're going to set up a virtual CUP molecular tumour board, which will run nationally, and hope that will make clinical decision making based on not just on the genomics patterns, but also radiological and clinical patterns. Importantly, this type of trial will build a huge biobank of samples for future research initiatives. So watch this space for when it opens. Importantly, CUP-COMP does not include access to targeted treatments, which is ultimately what patients really need in this disease type. However, later this year, we also have another trial running out of Manchester called Determine, and this will include patients with CUP. It's a very complicated trial. It's an umbrella basket platform trial, and it's actually used to treat patients with rare cancers or common tumours with rare genomic alterations. The overall aim of this trial is to assess the efficacy of existing targeted therapies, but in new indications such as CUP, and to look at the impact of the genomic, the transcriptomic, and the immunological context in determining response or resistance to these targeted therapies. And ultimately, if there are positive findings, so for example, if it does work in CUP patients, depending on what the mutation we find is, we want to be able to directly translate this to the NHS through the Cancer Drugs Fund to provide new treatment options for patients. And the NHS is certainly backing this type of trial. And this is looking to open by the end of 2021. So what does the future hold for CUP research within the UK and elsewhere? So we've got a number of investigator-led trials that are already about to open and also running the CUP clinical trials. We hope to do more subtype pathway specific work as a result of this. We need more research proposals from interested investigators throughout the UK, and there are a number of organisations that can fund this research. We just need to think about what research to put forward for this. We probably need to do more quality of life and psychosocial needs research, which I haven't really discussed today, but Kaikin did mention the CUPA patient decision aids, and we need to think about what the patients want as well. We hope in the future, and we're almost there now, where we can get precision medicine for all of our patients. The genomics boards across the UK are hopefully helping with this. And I haven't had time to mention today Target National, which is another large national trial that will give access to ctDNA measurements across the experimental cancer medicine networks within the UK. We'll be setting up our CUP molecular tumour board, which will run nationally. And I haven't had a chance to mention today the CUP Peace project, which is actually a post-mortem tissue acquisition study to try and understand more about the biology of CUP. This is running at the Christie and UCL. It's not an easy study for patients to participate in, but ultimately I think we need to do more biology understanding to see if we can improve prognosis for patients with CUP. And as Kaiki mentioned, I'm very keen on not just national collaboration, but international collaboration. The Australians have run a fantastic study, the SUPER study, and the next stage of that is called SUPER Next. And we're looking to try and collaborate with them on regards to our clinical data sets and also our biological data sets, and also the TCGA work that's come out of Spain and Manila Stella's lab. So we need to do more international collaboration to improve prognosis for patients. If anyone's interested in CUP research or has already got ongoing CUP research or ideas, then please feel free to speak to the NCRI CUP group. I'm sure they'll be more than happy to discuss your proposals. With that, I would like to thank the team of people that I work with in Manchester, and also the UK CUP investigators for supporting a lot of the research, and particularly John Symons and the Cancer of Unknown Primary Foundation, who have been a huge supporter of research within the CUP field, and importantly, the patients and their families. Thank you.
So thank you, Natalie. That's fantastic. And again, thanks to Sally for giving me a great talk. We're going to go to the panel session now. So I invite to the panel John Symons, who's the founder of CUP Foundation, as well as Gillian, who's a CUP nurse consultant working in Edinburgh with Sally. And I'm going to first of all go to the kind of most liked questions in the chat. And so what someone said, thank you very much. It's a fascinating webinar. I think you've taken on it a little bit, Natalie, so maybe expand on this, and maybe with John. This is like, you've talked about some collaborations, amongst the UK and internationally. Can you go into a bit more of that? And then further to that, you've talked about research, and of course, research needs funding. So and then another question right onto that, on top of that, is, well, where's the funding coming from now and in the future? And John, I'd like you to comment too, because of course you've done a lot of this work in the run up to setting up all these support groups for your patients. So Natalie, could you take that on first?
Yeah, sure. I mean, I think, I've got to be honest. I mean, John Symons and the Cup Foundation has kind of brought a lot of us together through some of his international conferences. And I met Richard Tothill at the last conference, and he's kind of one of the main investigators in Australia. And I think, following that, we've had multiple discussions about what we can do going forward, how the UK Cup research scene can collaborate with the Australian Cup research, because they've done a lot of excellent Cup research in Australia. We're already talking to Spain about the TCGA work. There's a number of sites in America that we're talking to. So I think international collaborations are getting commoner, and I think it's getting easier as well. And obviously we've all been restricted over the last kind of 12 months due to COVID. And I think I think we need to talk more. We need to look at ways to fund this research more, which ultimately is always the kind of holding. But I think we've been very lucky to get Innovate UK funding for Cup research. I think if we don't put the applications in, we don't know if it's going to get funded. I think it's an area of unmet need. I think it's an area that people are interested in. And I think actually, if you put these funding applications into some of the larger organisations, then I think it is an area that does need that funding. I think if you put the right and the well-written application in, then I don't think there's any reason why it wouldn't get funded.
Great. Okay. And John, do you want to?
Yes, as Natalie said, we run international conferences every so often, which bring together experts from all around the world. And if you want to look at some of the data from previous conferences, they are on our website in the research section. From my perspective, I'm always very keen that people put forward proposals about Cup research. We do fund a limited amount of research within our resources. But it's much more, to my mind, it's not the issue isn't all about funding. There are funds around. It's about getting new, fresh, interesting proposals relevant to the current situation within Cup. Okay,
great. Okay, so I've got a question, maybe a direct to Sally and Gillian. So someone said, do you know anything about the quality of life of patients diagnosed with Cup compared to a patient diagnosed with a site-specific cancer? And I would just like to add to that, Sally, one of the questions some of the data you showed was that, even in a patient who presents, you eventually find a primary who presents unwell, seems to do very poorly, okay, as well. So I just wondered whether you can talk about that. So maybe first of all, Gillian, as one of the Cup CNSs at the front door, what is your experience in using the Cup diagnostics, and anything else you want to add about trying to assess, properly the quality of life for our patients?
Yes, I mean, they have, if I say they've been quite a difficult group to try and capture quality of life in the past, but that's not a reason not to do it. And there certainly has been work that was done in Southampton. I think Richard Wagland and Alison Richardson have done that. We in Edinburgh have done some qualitative work in terms of trying to capture patient experiences, which certainly has highlighted the challenges of uncertainty and pathways to a diagnosis, but that was done quite a few years ago. Now, being part of the NCRI, we are really keen to test out the decision-making aids, and a core of us are going to look at doing that and evaluating them, and doing that sort of systematically across different centres in the UK. And there's also interest in work at looking at patient-reported outcomes, and we have been involved with some of Peter Hall's work, who's done a lot with websites, patient-reported outcome websites, and we have contributed to that, and we were actually really surprised that the uptake was very good in Cup, and that was a really useful way of actually trying to systematically assess quality of life and symptoms, and do it prospectively and actually act on the scores that people were actually reporting. So I think there is an interest. There's still a lot of work to do, but I think with having the NCRI, that will be really helpful, because we can then do it collectively across the country.
You're on mute, Kaikeen.
All right, Sally, we can't see you and we can't hear you. I can't hear myself. Can you Or you can move on.
Yeah, I mean, I don't have much to add to Gillian. Actually, I think that's absolutely right. And I think we've identified the additional sort of stress around patients with the unknown part of the CUP diagnosis. That word is a sort of word that we as doctors don't like particularly. We like to know things and be able to tell patients a diagnosis, and it feels like an unfortunate term actually to give a diagnosis of an unknown, because it feels to patients, I think, sometimes as if we just don't know, whereas actually we do know. We know it's an unknown primary, and that is a diagnosis in its own right. And we were certainly interested in what the additional impact on quality of life for patients about that whole terminology and the unknownness, and the fact that the pathways to diagnosis can be so varied and diverse and difficult for patients. But as Gillian says, it has been a wee bit hard to capture some of that.
Sure. Great. I was just saying that there's a stream of questions for coming through. There's many, so please like the ones that you like. I'm going to actually take on one of the ones from Mike, the pathologist, with regards to Capisco. So he's asked, is the recruitment going to be rigorous enough across different centres and countries to ensure that true cancer in primaries only are included? In my experience, the ability to find primary tumour sites is very dependent on the depth of experience. Will tissue of origin be testing on Capisco? So I'll take that on as actually the chief investigator for the Capisco in the UK, but both Sally and Natalie also are part of this. So I think the first of all is we are the top recruiting country for this study, and we have, as a group, actually taught. I mean, it's a very rigorous process. All I'm going to say is that there's almost no way they're going to let us put a non-cancer confirmed CUP. In fact, they go beyond ESMO guidelines to ensure we're not missing anything, and they sometimes insist on us doing PET scans and things that we wouldn't normally do, because they are really keen to only treat these kind of poor prognosis CUP patients. So I can first of all say it's incredibly rigorous. In fact, it might be their downfall, but they've been publishing some work recently about how good they've been in helping the investigators sites find the primary, and they say, well, are you sure this is not a sarcoma or something like that? Sometimes to the cost of us, because we just desperately want them to have the targeted therapy. So I would say, and I'd like to reflect on what Natalie's experience is as well, but I mean, I've been very lucky, in fact, of getting a number of patients on the study, and I've had my first patient who's actually completed all their chemo and atezolizumab immunotherapy and come up to the other end. So already is alive with no visible disease after 2 years, and he was, I still feel, a genuine CUP. So I agree that you've got to have sites that can do it well. The UK has got a great collaborative network because we have the CUP MDTs. It's good, and I won't say that we have seen other countries, and we've tried to advise the. I now sit on the TSC. I kind of advise the Roche team. There may be some countries where you just think, are you sure you want to invest so much time and money in those sites, because they don't really have an established CUP pathway. So I'm going to just stop there saying I think it's incredibly rigorous. So I don't think we're going to get non-CUPs in the system. But Natalie, do you want to comment on that as well?
Yeah, I mean, I agree. I think they're very rigorous. I think there's about a 50% screen failure rate for various reasons. Sometimes they find a primary, sometimes there's not enough tissue left to do the diagnosis. And I think, for the patients that go onto that, that's a great option. However, I do think there's a lot of other patients that may be not suitable for Capisco, but we still need to be able to understand more about those patients and those diseases. And hopefully with some of the other studies that we're doing within the UK, we'll be able to do that. But I think, the results of Capisco, will be extremely informative going forward for the very specific groups that we're allowing onto Capisco.
I just want to add on that. Someone's asked about immune research or immunotherapy for CUP. Do you have a view on that, as you do a lot of early phase? As does Sally, there's an immune arm in Capisco, and then the vast majority of patients are getting onto immunotherapy because there's no other targeted treatment. What's your view on whether...
Yeah. I mean, I think as in all cancer types, there's a role for immunotherapy in some cancer types, not for others. There's obviously various different immune biomarkers that we use for different, and every cancer is different. So, it's a huge minefield. We need to understand across our CUP cohorts who we think is going to respond to immunotherapy. And I think there are some that will and there's some that won't. That work is definitely ongoing, both within Capisco and outside of Capisco, in the hope that if we can detect those patients. So, for example, if a CUP patient has a kind of microsatellite instability, I would absolutely want to put them on immunotherapy if I could, but we can't do that at the moment outside the context of a trial, and I think that's what needs to change.
Very good. So I've got another very light questions. and I would maybe take this to John and Sally. Says, if patients that present with CUP were diagnosed earlier, would it be more likely that the cancer site would have been identified, i.e. do better early diagnostic programs reduce the number of CUP diagnoses? So that's a massive national question, but maybe I take this to John first, because you kind of helped set up the quality control issue, and then maybe Sally, your view, having done a lot of work with your database. So John, over to you.
I was rather hoping Sally was going to be asked first. Early diagnosis is obviously always important for all cancers. I think what will help in the future is if we can get more recognition of molecular profiling, gene expression profiling, which is not recommended within the NICE guideline, except for people on trials. So it's not standard of care. So I think it's really important that we can start having, we have research that will actually prove the benefit of molecular profiling through outcomes, not just changing the nature of treatment.
Okay, and Sally?
Yeah, thanks. I mean, I think absolutely earlier diagnosis is better. I don't think it will reduce the number of CUP diagnosis unless CUP is used in its very broad way, which it is still used in many places when we're really talking about MUO. So undoubtedly, patients presenting late or having very slow diagnostic pathways who are not fit for a comprehensive investigation workup will be given a label which should be MUO but is sometimes CUP. But I think that actually you probably increase your diagnosis of specific, you're able to hone down that diagnosis into CUP by having more time to investigate and properly get tissue, look at the tissue properly, get more biopsies if needed to make sure you're dealing with the right cancer. So I think, again, it's that difficulty between MUO and CUP diagnosis. Earlier diagnosis reduces the number of MUOs and increases the number with a specific diagnosis, either of a specific cancer or of CUP, which is a specific cancer type.
Okay, great, Sally. So we're almost running out of time. There's so many other questions I'd like to ask, but I think this is a nice wrap-up question to the panel. So someone's asked, if there was one thing, and be 30 seconds, one thing you would change about the current research environment that would support CUP research, what would it be? So I will start with Gillian. Sorry, I'm just seeing what I can see on the bit. So Gillian, what would you change about anything?
Goodness.
Maybe if you had $1 million as well. Let me the question, $1 million question, what would you invest it in?
Oh, goodness. Well, as a nurse, I wholeheartedly support the medical research that's going on in CUP, and it's fantastic. I've worked with Sally for 10 years, so therefore to see this progress is fantastic. But equally, I would like to have up there the acknowledgement and recognition of best supportive care as being an equally important treatment option and modality for patients, because there are still many, many people who will not actually get to treatment. So that should be of equal value.
Okay, very good. Natalie.
I think what would make a difference for CUP and other rare diseases is more integration of research within core NHS business.
Okay, nice and sharp. Sally.
Yeah, collaboration, different centres collaborating both within the MUO space and early diagnostic pathways, which I think are hugely important. I've got a big interest in pathways to diagnosis, but also then collaborating research networks, as we've now established within this NCRI subgroup, which is fantastic, and that has allowed this dialogue and this discussion across the country and hopefully internationally.
Great. And John?
Yes, international collaboration, extremely important. I think my one thing really, if I had to stick to one, would be getting an understanding of CUP biology. It is quite extraordinary that we don't have that. There has been some good work in Greece up to now, and I think some of the work that Natalie is doing in particular may help resolve that. Finally, could I just add to Gillian's point about palliative care, which it's always beneficial to have research on patient experience and in particular palliative care. As has been mentioned earlier, palliative care early in the pathway is extremely important, involving the patient in options about, particularly those with poor prognostics, poor performance, poor prognostics, is to get the patient to understand the alternative routes, palliative care information, as well as information about continuing SACT.
Great, and my only comment is that I just want the CUP to be more front and forward in our minds. And it's great to work with this team, and I think the UK is actually doing some really great work, and we need to show that. And I think that's really what we want to show today. So really, I want to say thank you for listening. I think that on the chat there's we really want feedback about the session and how it's worked, not only in CUP but how this whole event system has worked. So please send us feedback, good or bad. And I just really want to then thank everyone for listening to us, and please look forward to the kind of further program of events on the NCRI virtual website. So again, really thanks everyone for dialing in, and I'd like to thank all my panelists for hopefully what you will find a really enjoyable session. So thank you very much. Take care.